This is a very small topic and very interesting topic. And many of us, many ophthalmologists and neurologists, everybody would have come across this topic very frequently. And it's nowadays it's very easy to pick it up also. But the problem is when to pick up, where to pick up, how do you pick up this disease is the problem. Because these diseases have one wide variety of clinical manifestations. So they don't end up with only to one primary consultant. So they move on to one doctor to another doctor, another doctor, another doctor. They will keep on moving to one another because the recovery will not be just like that very easy also. So before that, so we need to understand the pathophysiology of the diseases and how clinical manifestation, how the imaging features will be. So then it is treating the disease will be very easy. Okay, let's go to the topic. So this is the agenda which we're going to see about the basic things about this disease. First, we see idiopathic intracranial hypertension. Hereafter, we use the word IIH from this slide. Okay, so IIH, we all know it's the term we use idiopathic because there was no causes identified because you don't see any underlying disease in the brain, but still you get some kind of problems in the brain leads to some various amount of clinical manifestations. So sometime you have seen our report saying pseudotumor cerebri as this is another name for this disease, and main symptoms which patients come to us is a headache. But you have, as I already told you, it's a very different type of clinical manifestation they come to us. And this slide says you variety of presentations. So sometimes the patient may go to first ENT doctor for this consultation saying that I have a ringing in my ear. So they do some test and okay, you are fine, normal. Again, the patient would have shoulder pain or knee pain. They go to one more doctor. They're saying that, okay, you are fine. Okay. So it's like patient moving from one doctor to another, keep on changing because there is so much amount of clinical symptoms which you may. Once they go to neurologist or ophthalmologist, they can pick it up easily. But coming to this doctors is the real problem because they don't just like the comment, I have the problem. They have to meet the right consultant. This is not happening in India because if you give 50 rupees, you get many consultant as a neighbor பக்கத்து வீட்லயே ஒரு டாக்டர் எதிர் வீட்லயே ஒரு டாக்டர் நிறைய டாக்டர் இருக்காங்க இல்லையா so they keep going from one doctor to another. That's the problem in India. So you get this kind of diseases in still more common also. Okay, so now you should understand the pathophysiology of how this disease is happening. See, any disease which I recommend PG students to listen to this because any disease which you read, you always read about, just don't mug it up about the what the problem happened. Just read about the pathophysiology of the disease because only when you understand how the disease is happening in your body, you can able to treat the disease well. This is how my professor used to tell. முதல்ல வியாதியை படிக்க கூடாது, வியாதி எப்படி வருதுன்னு படிக்கணும். This is how I learned my radiology in my PG days. So I recommend you to go for first read about the epidemiology, pathophysiology, then last you go to the treatment part. So this slide is very important, and as you can see, this is an what are the hypotheses or what's the problem which is helping us to solve this problem. So normally, due to the hypersecretion of the choroid plexus, CSF fluid from the choroid plexus is the main culprit and main cause. But still, when the patient dies, we do postmortem, and you don't see any hypertrophy of the choroid plexus or any choroid plexus papilloma, nothing is there. But still, they say that hypothesis says that it is an hypersecretion of the CSF is the main culprit. Second more common causes, even though the secretion is normal also, the absorption of the CSF fluid may be a problem. That's the second most cause. And the third and least most cause is the increased venous pressure. So this is problems with the intracranial, within the brain, the problems. But sometimes brain may be normal, that problem may be with the other metabolic abnormalities. And we commonly see this IIH is very common in middle-aged female who are in the 30s, 40s, and they are almost invariably obese individual. So that is why we recommend a female who is coming up with you this age group and this category. First you have to screen an optic disc and to check for the pallor, and they go for MRI. This is how the protocol goes like this. So abdominal mechanism says that due to the increased abdominal mass, the thoracic pressure is increasing, so thereby venous pressure increasing, thereby you cause hypersecretion changes. So you all know this. There is a term called leptin, which is in the growth weight substance hormone, which is happening in the body. When because of this hormone, they cause a small effect over the choroid plexus, which is a prothrombin effect. So thereby causing microthrombosis in the venous sinus. That's why if you see pregnant patient who are a middle-aged female who are showing OCP pills, they have a hypercoagulable state in the body, thereby causing this kind of IIH problem. So this says that indirectly there is something in the body which is making up this problem. Okay, now we know what is IIH and how this happens in our brain. Now you see the imaging findings, what we see. What are the imaging findings? I'll tell you, show you a variety of imaging finding, which is it's in there in the literature, and we see also. But not all this imaging feature which I'm going to see in day-to-day practice is not possible. So I have explained in coming over next one of 10 to 15 slides. I have seen you yourself can pick it up when you see this image, because radiology, you see film, you have seen all film reports, right? So we have a diagnosis center we used to give big films in saying diagnostic image. ஏரோ போட்டு காட்டியிருப்போம், நிறைய பேர் பார்த்துருப்பீங்க, இதுதான் ஃபைண்டிங், இதுதான் மட்டும் பாருங்க அப்படின்னு. So that is why I have put all those imaging signs here. First and foremost sign which we see common in IIH is the empty cella sign. So this is you're working. Okay. So this is a mid-sagittal image of T2 brain, plain MRI brain, showing that there is an ovoid structure which is sitting there. It's called as a pituitary gland, which is a normal looking gland. Okay, as the pressure in the brain keep on increases, the anterior pituitary becomes smaller, and you call it as partial empty cella sign. As still more, the pressure is keep on increasing, and you see the pituitary gland has been almost collapsed, and you see called as empty cella sign. So it's a normal brain, partial, and this is empty cella sign. Okay, this is the first sign. Second most is the posterior stalk displacement. This image which you see in the, even you can see in the plain MRI or else in the contrast MRI also. Here is the normal anterior pituitary. The stalk is almost in the midline. As the pressure keep on increases, the CSF flow which is going faster into the cella, causing this posterior stalk of the pituitary shifting backwards, thereby causing posterior stalk displacement. This is the second sign. And this is meningocele. This is very quite rare. Almost in my 10 years, I have seen only few cases in IIH. That too, end stage patient who have not gone treatment and come for us, you have find these findings. So this is a coronal T2 image of the brain, which showing a smooth convexity of the brain parenchyma, and there is you see the brain bone. You don't see any changes in the bone. As the pressure keep on increasing, there is a small defects in the bone. Can you see that small things? And there is outpouching of CSF fluid structure is called. This is called as meningocele. This can be seen even in the plain CTs also. That is why we always say that we don't just treat patient coming with you for some disease, just don't see in only one window. That's why we think brain, we come only don't see brain. You have to see the surrounding structure. You have to see from the scalp. You have to see the subcutaneous tissue. You have to see the bone. Everything is matters. Every small detail anatomy which help you to diagnose which diseases which is early also. See here, the same disease which you see in the bone window, if patient would have come for CTPNS or something else also, you can pick up these findings. This can be very subtle, but it can make a big defect in your big change in your treatment for the patient. Okay. Next comes the enlarged Meckel's cave. Meckel's cave is nothing but a CSF filled structure on the other side of the cavernous sinus. Normally, almost about 5 mm will be in the width of the real structures. When the pressures keep on increasing, you can see this small 2 bright dots in the other side of the cavernous sinus. When you measure, it comes more than 5 mm. You call it as enlarged Meckel's cave. This is a very interesting sign. You all know that optic nerve tortuosity. See here, normally, this is a zoomed image of an axial section of the orbit. Can you see this is the round globe structure which is orbit, and here see the linear structure which is come across like this is the optic nerve. In a normal patient, you see an optic nerve is a normal linear slender thin structure is there. So in case of IIH, what happens is this: the optic nerves get tortuosity. We call it as vertical tortuosity. This is called a smear sign in radiology. In radiology, we have many signs. Ella disease we call it as some sign. So that to have a food sign, because we don't we don't forget. We always keep food signs in radiology is very common. And here we see is the smear sign. The smear, what we mark here is the orbital fat which is getting or herniated into the optic nerve, causing imprintation. This is called as vertical tortuosity of the optic nerve. And this is called as optic nerve sheath distension, ONSD. So what happened is here is many of the time now young ophthalmologists who keep writing like this. So kindly measure the OSND values. So before that, you don't get this kind of values measurement. Nobody asks. Even radiology also, we don't write these values also. Now people are like specifically asking contrast MRI, please write OSND values. Okay, here is the axial image, plain image, which we see here. As I already told you, it's a plain good optic nerve straight line structure. But the thing is, where to measure this OSND is very important, because just like that, you cannot measure somewhere else. You give the report and it won't be matching your clinical findings. So where you have to measure is exactly 3 mm below the posterior globe of the optic. This is where you have to measure 3 mm below the optic posterior globe, and you have to measure. You can measure either in the axial plane or coronal plane, wherever it is, but you have to measure here. More than 6 mm we considered as an abnormal. Normally 4.2 to 4.6 mm we consider normal. 6 to 8 will be in OSND is increased in the IIH. Next is the inferior positioning of the cerebellar tonsil. This is quite rare finding, but you don't see commonly. And the interesting part is even the cerebellar inferior tonsillar herniation is seen in some of the common normal individuals also. Maybe 2 mm, 3 mm is normal. We consider more than 5 mm below this line, we call it as abnormal. This is very rare finding. Just for completion's sake, I have added this. And here, this is one good sign: optic nerve head enhancement. This optic nerve head is, you always see there is a small protruding structure here. Can you see that? This is optic nerve which is getting into the posterior of the globe. And when you see post contrast study, you see a bright spot here. This is a normal slide, and you see a bright enhancing spot. This is called as optic nerve head enhancement. This is the sign to say it's in case of IIH. And this is one of the very most important sign, was what we call as occlusion of the bilateral dural venous sinuses, predominantly in the posterior aspect. So in my clinical practice, which I have seen so many slides, which I have seen you, but none of them turned out to be always in all the patients. But this one finding will tell you this, which very commonly we say that it is a case of typical IIH. This is a very early sign to pick up in MRV to say it's an IIH. Can you see a tubular structures here in wide lines? Can you see that? This is the transverse sinuses which is there. And when you see here, there is a cutoff of signal from in the both sides, either side. This is called as occlusion of the bilateral transverse dural venous sinus. It's a typical sign for IIH. Okay, now we this sign which I already told you also, the protrusion of the optic nerve. Even the optic nerve vertical tortuosity is one more sign, and the optic nerve head enhancement is a second sign, and third is optic nerve head protrusion. This is another third sign. So when you ask for IIH, you have to write MRI brain with orbit cuts and MRV. This is the complete study you have to write, so that you don't want to miss any of these findings. These are the other signs which we don't want to discuss because it's not classically or typically seen in day-to-day practice. You all know, just for exam sake, you can write this TW bright spots in this posterior aspect of the globe, and the slit-like ventricles are tight space of ventricles. Okay, so now you have seen the clinical manifestations, how radiological appearance will be the and all the things. So this is the diagnostic criteria which you have to follow. Number one is papilledema. Almost invariably every patient will be having this. And when you examine the patient, 99% they will be very normal, or sometimes some of the patients may have either 7th or 6th cranial nerve palsy to be. If there is other nerve palsies can also happen, but is very quite rare. Most commonly 6th or 7th nerve palsy will be there. And neurological imaging, and you see these four structures: empty sella, posterior globe flattening, optic OSND, and transverse sinus stenosis. And when you see CSF culture, when you take, then it will be 100% normal, and opening pressure will be more than 250 millimeter in adults and 280 in children. This you have to do it in a patient with a sitting posture. That is also very important, the pressure analysis to be done. Okay, so this is the diagnostic criteria for IIH, which you all have to practice day to day. Okay, so now summary of this disease, what has happened. So this is the what all the signs which I have told you, this we have kept in all this in one slide. See, here, anterior aspect, you see the optic nerve tortuosity. This is called as I told you already, this smear sign. And here is the enlarged Meckel's cave. And here the pseudo-meningocele formation and optic nerve head protrusion, empty sella, and transverse venous sinus stenosis. So these all imaging features classify as IIH. But is it really what I have shown you daily? Are we seeing now? It is not happening, because as I already told you, all patients will not have a typical blurring of vision or headache. Many patients can come with many different symptoms, and we have to retrospectively, we have to find this finding. So here one middle-aged female who is in early 30s came with complaints of neck pain for evaluation. This is from orthopedician actually. So we have seen, as you see, this is a mid-sagittal image of T1, T2 of a cervical spine. You see a block vertebra here, and this is a small, ignore this finding. Okay. So incidentally, what we see is the empty cella. Okay. So now we radiologists have a habit to, what you say, to attract the referral doctor. We tend to go down to diagnose more. Okay. This is not only me, every radiologist does it. So out of curiosity, what I have done is we have screened the patient, whether the patient is an IIH or something else is there. Okay. Fortunately, we have screened two sequences of MRV have been done, and mid axial sections of the thin cuts of the orbit have been done. Interestingly, the patient had an vertical optical nerve toxicity and bilateral transverse venous sinus narrowing. So this is a typical case of IIH. The headache is, the neck pain is not due to the some problem in the cervical spine. It is problem in the brain. So this is what I was talking about. The patient will not straight away coming and saying that I have IIH, get me treated. Okay. They come to you from the different departments. So you have to retrospectively diagnose this problem. So this is one typical example of this IIH happening in day-to-day practice. Second and foremost common, what you have seen, oculomotor nerve palsy. This is one of the cases which I got. Patient had a simple palsy, and here and there the patient got treating. Some of them told get an MRI done. So MRI has been done. This also shows a typical empty cella and optic nerve. Not much toxicity, but still when you see the optic sheath is getting thickened, and you see typically bilateral narrowing of the transverse venous sinuses. So this is the second variable presentation you may get. IIH can happen in day-to-day practice. And this is one interesting case which is very tough to decode actually, I would say. This patient had a recurrent history of fall. He keep on falling down somewhere else. He will treat somewhere else. Okay, go to one hospital to another hospital, keep on moving from one hospital. And it came out to be like the MRI has been done. You see multiple black dots here and there. We call it as superficial hemosiderosis. This is nothing but deposition of blood in the brain parenchyma, superficial part. Other multiple areas of subarachnoid hemorrhages or intracranial hemorrhages happen. And because of the chronic hemorrhages, you see hemosiderin deposits here and there. And interestingly, this case referred by a neurologist. I always like neurologist actually. Why? Because they are the one doctors who always write the study in a very complete way. இப்படிதான் எடுக்கணும், இப்படிதான் பண்ணணும். That's why because the revenue also good, no? They take more, so we can get more revenue also from them also. So here, this doctor, this gentleman, they have written nicely. So he just written MRI brain with contrast, MRA, MRV, all those screen, blah, 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 all compressible come somewhere around 14,000. Okay, fine. Okay, now we have seen this superficial cerebrosis, and we have seen again the imaging finding was found. But I was worrying about why IIH can cause superficial cerebrosis, and I have Googled it also. Sometimes Google may help us. Even colleagues cannot help, Google will help. Okay, I have read an article saying that superficial cerebrosis may also happen in IIH. Then I spoke to the referral doctor saying this is case of IIH, and the patient had to keep on recurrent fall, and maybe getting in. Okay, once the pressure was corrected, I didn't have a follow-up MRI here. So patient was corrected, and there was no again history of fall was there. It was quite surprising clinical finding, but still it may happen. So that's why I told you variety of clinical presentations can happen, and the patient may run from one department to another department. It's when the patient land up with you, it's up to you to diagnose what next. Okay. Okay, now we have almost finished IIH. Now we come to the second topic we call as cerebral venous sinus. Hereafter we call this term as CVT in next future slides. Okay. CVT is previously we do see CVT is very common, but after the COVID, we see more CVT. Maybe a prothrombin effect or the vaccine. We don't know what. I don't want to go into deep into it, but we are seeing more and more CVT. I used to get more CVTs in a patient who had a sinus problem. You have fungal sinusitis, no? You have all seen, no? Black patches in the face also. So we have seen in those 3 years, I have seen for 5 to 10 cases, we have seen of CVT in a patient who had fungal sinusitis. They have presented with CVT also. Okay. So this is a less common form of cerebrovascular accident, but if you don't treat it, it become very lethal also. Okay. So this disease also have a heterogeneous appearance of clinical findings. So early pickup of this finding is very, very, very important. So advancement in the neuroimaging and treatments have improved the good outcome for the patient. So the causes, when you see this CVT is wide number of causes is there. Then I don't want to go into deep, but always remember female who is on oral contraceptive pills, or a hormone replacement. This is one history is very important. And you see dehydration. Why? Because it's in rural areas, I don't know cities, I don't know how it is, but rural areas in Kallakurichi, places like us, we used to get more CVT because patient who is an alcoholic. So they drink, they have a quarter, they sleep well. After the 2 days, again they wake up in the morning, one more quarter, they will sleep. After third day, they keep on vomiting. Then they count headache. Now you come to MRI brain, you will get a CVT. This is how the classical presentation in rural areas. But city, we don't know how this happened. Used to get this. That is why ma'am also was telling history is very important. 85% of the disease which we see here, all the findings which causes which I have mentioned, when you go back to history, almost 85% of the patient will have either one of the disease will be matching with the CVT. That is why in all the disease which you see, history is very important. Talk to the patient, keep talking to the patient, keep talking to the relatives. You will get some ideas. So when you want to be successful in your practice, always go to basics is first. Basics should be strong. That's why I also, my success of stories is not just radiologist also. It's about clinical radiologist. You have to train your juniors. This is how the protocol has to be done. You have to define yourself. That's why if you do like this, your practice will be very good. Okay. So now before going into the disease deep, I also say that pathophysiology is very important. This is a bit small anatomy, which you see. Brain, you have multiple venous structures running in the brain. And here is a major veins which I have to discuss is a superior sagittal. It's one of the biggest vein which is running in the superficial surface of the brain. Next comes the inferior sagittal sinus. And here is also sigmoid, transverse, all those blah, blah, blah sinus are there. Oh, don't need to much go into that. Just know these are the sinus which is there in there. Because of this sinus occlusion, the problem happens. That is why we want going to discuss about later. Okay. So 90% of the patient, they complain mostly with the headache. But the headache can be different. Like some patient may like with a sudden onset, a throbbing headache, or some patient may have a gradual onset headache. Some patients may have headache intermittently. I was normal for one day, next day I was normal. Next day I have severe pain. It's the headache can be variable percent. So that the delay in diagnosis is the problem. So where he goes, that's the problem. He go to general medicine, he give 2 tablets and get okay, now normal, you can go home. He go to another doctor, he says that, okay, another fine, you get a CT done, plain CT, normal, okay, go home. Another after 5-6 days, the patient has again severe headache. Now you go to neurologist, they saying that, okay, you go for MRI brain with MRV, now you diagnose CVT. This is the problem. The completion of the study will happen. The diagnostic modality of investigation, what you choose to write for your patient is very important. Okay. Next is this can be progressive or localized also. It can be worsened by Valsalva maneuver. I'll share you what this clinical future in the next slides. And reduced consciousness carries worse prognosis. You have to be very sure about this finding, which I have seen also. Because reduced consciousness with CVT has a very worst prognosis going to happen. Even though imaging radiological features will be very subtle, when the patient, his consciousness level is very less, BCS score is very poor, then it's time to refer the patient to a higher center. Okay. And sometimes we can see a rarely psychological behavior change. These three, I'll tell you kuti stories in the next future slides. Okay. So most common site of thrombus formation is the superior sagittal sinus. Second is the transverse, then comes the sigmoid sinus. And many of the time, multiplicity of the thrombus in the different sinus is also possible. And mostly we see multiple involvement of sinus is the most common finding in day-to-day practice. So what are the investigation modality available in the market now? It's the most first and baseline investigation is CT. Second comes the MRI. But the confirmatory diagnosis of CVT is CT venography is a confirmatory diagnosis. Okay. So this is the first and easy sign to you everybody in the radiology resident, they would have seen. This is called as hyperdense sinus sign. Okay. So the plain axial CT of a normal human brain shows they see a linear hyperdense structure here. I will tell you a story about this sign. This is very interesting. During my second year PG resident, I was reporting a CT brain. A patient came with the CT brain. I was seeing the console. Okay, patient was taken CT, and I became second year. No, I became half consultant now. Okay, I was scrolling the images, and I have given normal study. My assistant was sitting a sip of tea, and he was saying, "Lokesh, did you finish?" Yes, sir. Normal, sir. Did you ask history? No, sir. It's normal brain. Okay. Then he told me to go to check. Ask for history. He was sitting like this. I said he's having headache, sir. Now you see the image. I said, it's normal, sir. Okay. Now you go back again. ask the patient to cough for 5 times and then come back. And என்னடா இந்த ஆள் லூஸ் மாதிரி சும்மா சும்மா காலையில ஓகே ஃபைன் ஓகே சரி இட்ஸ் அசிஸ்டன்ட் நோ ஓகே ஹவ் டு ஃபாலோ இட் தென் ஐ வென்ட் பேக் அண்ட் ஆஸ்க்டு எவ்வளோ நாளா தலைவலிக்கு ஆல் தோஸ் ஏன்னா பிகாஸ் ஹி வில் கம் அண்ட் ஆஸ்க் மீ வாட் எல்ஸ் யூ ஹேவ் ஆஸ்க்ட் ஓகே வில் ரைட் டீடைல்டு 10 இவ்வளோ நேரமா நான் இரும சொல்லி பார்க்குறேன் அப்படின்னு இல்லை சார் வேற ஏதாவது கேட்பீங்க நான் இப்போயே கேட்டுட்டு வரேன் ஓகே ஃபைன் ஓகே ஐ வென்ட் தென் the moment I asked him to cough 5-6 times, the headache was so aggravating. He was scolding me, the patient. I was having little headache. Now it's worsening. Go away. Now you tell me you have done all those things. Now you see the CT again. You tell me. I was still more confident. I said it was normal studies. Then he gave me idiot. It's not like that. Why when somebody telling this history is very important. You see plain CTs 95% of time you have to adjust the window width and window level. What is called as window width, window level means nothing but the the grayscale image of the brain has to adjust. So you have to make the image little bit darker to see very subtle structure. So he just window level he have reduced and he showed me this hyperdense sign. This is called as hyperdense. Then he told it's a case of CVT. Then the moment he said the CVT, we have done the CT venogram on table and found out to be a case of CVT. So that's why when you have to listen to your seniors sometime to learn some good radiology. Okay, fine. So then this is the card sign. And as I already told, radiology is full of signs and foot signs. And here is the card sign, which you see is an inferior sagittal sinus. You see a linear bright structure we call it as card sign. And this is called as cashew nut sign. And see cashew, don't say exactly cashew, but this is called as cashew nut sign. So here subcortical or juxtacortical, you see a hyperdense image, which is like more kind of cashew. You have to remember like a cashew, okay? And surrounding edema. And this imaging is very important. You see hemorrhages in the brain, which is of non-vascular territorial, non-arterial territorial places. When you see hemorrhage, until proved otherwise, it's case of CVT or bleeding diastasis. This two diseases which present to you, which give you the appearance of unusual places of hemorrhage in the brain, irrespective of the history. Okay. So next called a delta sign. This is nothing but a bright delta-like appearance here in the posterior aspect of the sigmoid superior sagittal sinus area, and you see a cashew nut sign here also. And empty delta sign, nothing but an same delta. In post CT venogram, you see a small filling defect here, and you call it as empty delta sign. As I already told you, parenchymal hemorrhages. Sometimes the parenchymal hemorrhages can be a lobar hemorrhage. Such a big amount of hemorrhages can also happen. That is why when you see a CVT, you take CT in day 1, and you have to follow CT also is advised. That's why irrespective of the treatment, some patient may go into worse scenario also. So to document that, maybe a 20, I don't know, practice from 1% to another percentage, we recommend follow-up CT or follow-up imaging modality after 48 hours is gold standard. Okay, here see a small hemorrhage is a different patient showing a big amount of hemorrhage with surrounding edema. So as I already told you, the sinus thrombus can be a single sinus or multiple sinus also. It's a mid-sagittal T1 sagittal image of the brain shows that a linear hyper intense structure in the superior aspect of the brain. We call it as superior sagittal sinus thrombosis. This I still told you, multiple sinus involvement there. It's an inferior sagittal sinus, straight sinus, all the sinus has been involved, and some part of the superior sagittal sinus also involved. So this is a case of multi-sinus involvement in CVT. This is some of them bigger sinus involvement is easy to diagnosis, but sometimes cortical veins are typical named veins of the brain involvement. Diagnosis is very challenging. Only if you know the anatomy and the pathophysiology, then it is very easy to diagnose. This is a case of a linear. This is a case of CT which you have seen, a linear structure which is in the medial aspect of the temporal lobe with surrounding hyperdense area. Sometimes we initial PG recent time we still shows mass for evaluation. We recommend contrast study. So, but when you see other MRI will give you a 100% result. Then see blooming artifact along this, and we give MRV, and you see you don't see the basal vein of Rosenthal is there. Then it's a case of isolated thrombosed basal vein of Rosenthal. Okay. This is another interesting story which I tell you happened up. Here is a 21 year female, I guess. She got away from the home. She got after 2-3 days, they found that girl. and they found back into the home, and they found to be she is 3 months pregnant. This is what the history says. Now she is like altered mental behavior and psychogenic effect after 3 days. And they said Maria that what's Vepele something they will keep adipanga. So there is a python pay and something like that. And then the neurologist referred here this case for. And interestingly, this case found out to be a bilateral internal cerebral vein thrombosis, which is again you see the big round structures in the side of the basal ganglia. This is a case of internal cerebral vein thrombosis which has happened. So because of this, it happens to cause a this psychogenic behavior. As I already told, psychogenic behavior, altered in the behavior, headache, many different presentation patient may have. But history, why we have CVT was happened is because the patient has eloped from the home. 3 days she didn't eat well, and she's also pregnant. The blood is also hypercoagulable state. This all saying that okay, it's a case of CVT. Okay. Next is the sigmoid sinus thrombosis. This is a very interesting case. So the patient had complaint of ear pus discharge, and he came to us for for an MRI brain to saying that any internal brain involvement is there. You see here is a mastoid sinusitis is there. A patient is also diabetic also. So you see a small cerebellar abscess also. But beyond that also, a patient had a secondary sinus involvement causing a sigmoid sinus thrombosis. So always CVT may not be a primary disease. Sometimes secondary due to the infection. As I already told you, COVID times, we have seen many sinus thrombosis in a fungal sinuses. This is one of the typical examples says that even in secondary brain infections or secondary sinus infections, you will get CVT problem. So this is a common sinus which is thrombosed due to the primary brain infections. In meningitis, you can get superior sagittal sinus thrombosis, middle ear and mastoid sinusitis, you will get lateral sinus thrombosis, sphenoid, ethmoidal. This is also one important. The teeth and removal. We have seen many neurologists have seen this history. They have removed one tooth, and next day the patient had a severe headache, and they said, I don't know what to do. They come with the MRI and they'll find out CVT. So this is very important because the teeth extraction is also we have to very good. So teeth and supporting structures, when you see cavernous sinus thrombosis is very common. Remember next time. Okay. So I'll finish up with the two interesting cases which we come across. This case had an progressive rapid dementia. This is the only history. He was fine last week. He was fine. This week is returning second day, third day. Another MRI was done. Nothing much finding was there. Non-specific white matter signals are there. So we call it as small vessel ischemic changes. But still, we are not convincing why do small vessel ischemic changes can have a rapidly deteriorating. Then I advise to go for MRV. MRV says that there's a chronic venous sinus thrombosis. As usual, we Googled it. Google says that correct. Okay, CVT with rapid memory loss can also happen. Okay, I have given the report of rapid memory loss, maybe due to chronic CVT. Okay, this one case which is very important. Second is this female had a history of sudden throbbing headache. This is the only history we get. No trauma, nothing was that. She is not even pregnant. She is not even married also. So what we have seen is multiple linear structures. Can you see that? This is called a subarachnoid hemorrhages. Usually in CVT, you see parenchymal hemorrhages are very common. This is what the textbook says, but not for all patients. Interestingly, we see what is called as delta sign, which we see here. And we did a contrast study for this patient, and it turned out to be a case of CVT. So CVT, parenchymal hemorrhages, sometimes subarachnoid hemorrhages may also happen. So not all patients can have a textbook type of image of presentation to you. So this is a case of CVT with subarachnoid hemorrhages as a first clinical presentation to us. Okay, so pitfalls for diagnosing the CVT is many. I don't want to dig into detail, but just know hypoplastic, aplastic, slow flow sinus, abnormal course of sinus, old CVT, CVT with recurrence. These are all the pitfalls of sinuses which may cause problem in diagnosing the CVT. And last but not least, this is the very important acronym you can use for a stop for an intracranial hypertension. S for empty-sella, T for transverse venous sinus, O for optic nerve sheath distension, and P for posterior. So remember, stop. So upon finishing, I just want to make this slide is very important. Always please go for a detailed history. Every patient is important to us, and every patient attender, no, they are important for the patient. So always make sure that you talk to the attender before you treating well to the patient. Okay, because radiologists, we don't have that problem. We don't see patient attenders, we don't see patients also. We see only black and white images of the patient. Okay, so for you all, this is very important. And each patient is, remember, no patient is loyal to you. Any patient can sue you at any time. So remember, as madam told, keep everything in documented. Whatever you see, whatever drug you write, keep writing. You have seen radiology reports, recommended clinical correlation, follow up, advised. Why you are writing all those things? To make yourself, you are safe for the diagnosis. Okay. The next is multimodality confirmation of diagnosis. This is very important. Why? Because when you do a CT was normal, don't send the patient again, Arjun. Okay. Even though they have budget, don't budget. It's your duty to go for higher modality investigation. It's your duty to recommend what modality investigation next when the basic modality of investigation is negative. Okay. So don't hesitate for follow-up study. And if you don't know, ask for help to your seniors. And remember, it's always a teamwork. Not only one department is going to do it. Every department, every consultant is department in treating. Thank you for the valuable time. Good luck.